Okay, it says starting live stream again. So, hello and welcome to the European Resuscitation Council's Best of the Best session. Our apologies for the short delay in starting this session while we're addressing some technical issues. My name is Gavin Perkins and I'm very excited to be able to be chairing this session because this represents the best of the abstract submissions that was submitted to the European Resuscitation Council's virtual scientific congress. We have 5 top class and very interesting presentations to hear together over the course of the next hour. In terms of the structure for the session, we're going to have the brief video presentations played and then the presenters are going to make themselves available for questions. This is the best of the best competition and we have 3 judges from around the world who have kindly given of their time in order to assess and identify the best of the best science at this meeting. I'd like to go to my judges and invite them to introduce themselves, starting with Kate first.
Good morning, everyone. I'm Kate Berg. I'm an intensivist and cardiac arrest researcher in Boston in the United States, and honored to be here. Thank you.
Great, thank you, Kate. And Marcus.
Good day, everyone. My name is Markus Krevars. I'm an intensivist and professor of pre-hospital emergency medicine from Helsinki, Finland. Very happy to be here.
Sir Lockley.
Thank you very much, Kevin. Hi, I'm Andy Lockie. I'm an emergency physician from the UK and a postdoctoral researcher, and really looking forward to these presentations.
Great. Okay, so without further ado, if I could ask for the first video to be put up by Masahimi Akubo.
Hi, my name is Masashi Akubo. Today, I will be presenting a study of duration of pre-hospital resuscitative effort before termination of resuscitation for out-of-hospital cardiac arrest at EMS agency level. This study was funded by AHA Career Development Award. I have no other disclosures. As a background, we recently found variation in survival after out-of-hospital cardiac arrest between EMS agencies. We analyzed resuscitation outcome consortium dataset and found that survival to hospital discharge varied from 0% to 28.9% across 112 EMS agencies in US and Canada. We adjusted for patient level factors and EMS agency level factors. However, that variation slightly increased after adjustment. Question remains, what are underlying modifiable reasons of the outcome variation at EMS agency level? This is a study of in-hospital cardiac arrest. This study looked up association between hospital-level resuscitation duration for non-survivors and outcomes. Hospitals are divided into quartiles based on resuscitation duration before termination resuscitation. This study found that hospital in the quartile of the longest resuscitation duration was associated with return of spontaneous saturation and survival to hospital discharge. We thought this could be applicable to EMS agencies for out-of-hospital cardiac arrest. So our objectives are study variation in resuscitation duration before pre-hospital termination resuscitation at EMS agencies and assess the association between the resuscitation duration and patient outcomes. This is a retrospective analysis of the Resuscitation Outcomes Consortium, which is a prospectively collected multi-center out-of-hospital cardiac arrest registry between 2011 to 2015 and 10 sites in the US and Canada. We included adults with EMS-treated out-of-hospital cardiac arrest. Main exposure is median resuscitation duration before pre-hospital termination resuscitation at EMS agency, defined as an interval between initiation of CPR by EMS providers and pre-hospital termination resuscitation for those without ROSC. Primary outcome is survival to hospital discharge. Secondary outcomes are favorable functional recovery at hospital discharge, defined as modified Rankin-Scale score less than or equal to 3 and per-hospital ROSC. We use multi-level modified Poisson regression model. Patients are nested within EMS agencies. We adjusted for these patient-level variables and EMS agency-level variables. We included over 42,000 patients treated by 112 EMS agencies. This is patient characteristics and EMS characteristics. Median patient age was 66. About 22.2% had shock embolism. 36.6% patient had witnessed cardiac arrest. Median EMS response time was 5.4 minutes. Most patients had epinephrine and attempted advanced airway management. Majority of EMS had BLS and ALS crews and covered urban area. This is a distribution of resuscitation duration before pre-hospital termination resuscitation at EMS agencies. Median resuscitation duration was 22 minutes. We divided into quartiles based on the resuscitation duration before termination of resuscitation at EMS agencies. And this is rate of hospital to survival discharge. This is the rate of survival to hospital discharge at each quartiles. The survival rate varied from 8.6% to 12.9%. We adjusted for patient level factors and EMS agency level factors, and we calculated adjusted risk ratio for each quartiles for each outcomes. We observed no significant association between resuscitation duration and each outcome. Limitations. This is an observational study, so we evaluated association, not causation. This is a sample of selected EMS agencies, so external validity is one of limitations. There may be unmeasured confounding factors. As a conclusion, although we observed variation in resuscitation duration before pre-hospital termination resuscitation, the EMS practice was not associated with patient outcomes. Further research is needed to identify modifiable EMS practices that explain outcome variation after out-of-hospital cardiac arrest. Thank you.
Great, thank you very much for that very clear presentation and some great data there. In a moment, I'm going to turn to Marcus for the first question, but if I could reach out to the audience that if they have questions, please enter it into the Slido app, and I'll then pose it to the abstract author. So Marcus, if you'd like to go first, please.
Thank you very much. Very, very nice presentation. So in your sample, there's a variation of from 0 to 29% in survival. So I mean, that's remarkable. So there definitely are things going on here. And your hypothesis was to see whether this is related to the CPR effort, if some systems stop too early, so to speak. So I think it's a nice and a very relevant question. So my first question is, when you grouped patients based on CPR before the TOR was applied, you only looked at the ones who did not have ROSC. Is that right?
Yes, that's correct.
So in essence, if you have a system with a survival rate of 29%, then those patients, those 29% will not be included. Yeah. But in a system with a 0%, all patients will be included.
Yes, to calculate the main exposure, we only looked at those without ROSC. So
do you think that could create some form of bias that you have? I mean, based on, I mean, if you have a very efficient system, for example, that you are able to create ROSC quite quickly, then those patients would not be included in a way in dividing the patients into different groups, so to speak.
So those without ROSC was only included to calculate main exposure. So for the study population, we included all patients.
Okay. And then my other question is, so when you look at the patients that you have, so I mean, the cardiac arrest patients is very different, you know, shockable rhythm. Of course, the guidelines say, you know, you have to go on for 40 minutes, even an hour, whereas non-shockable rhythm, the guidelines talk about 20 minutes. So the difference in resuscitation efforts between the different agencies was massive. I mean, how can you have systems who only go on for 10 minutes compared to 45 minutes? So have you looked at specifically the patients with ventricular fibrillation compared to PEA or asystole? And the specific subgroup I'm talking about would be, you know, unwitnessed asystole. So I mean, some centers probably would not go very long because of the perceived very poor outcome.
Thank you so much for the question. That is exactly I'm going to look up because, as you mentioned, resuscitation duration before termination for those with shockable maybe matters. My next hypothesis and next step.
Great. If
Good.
If I can jump in now, if that's okay, because we have had a couple of audience questions, and in fact, one of them you've already posed, Marcus. So that's great. But Bernd Bottiger would like to know, do you suggest longer resuscitation duration? So I guess the question is, how do you interpret the findings from your study and what implications should they have for practice?
So I don't think we have any strong evidence how long resuscitation should be done before termination from this study, but because we are specifically looking at EMS agency level, not patient level. But there is a study looked up resuscitation duration for patient level at Resuscitation Outcome Consortium. So I think my bottom line is we cannot make any conclusion regarding resuscitation duration from our study this time.
Great. Okay. Well, thank you very much for a really nice presentation. I'd like to, congratulate you on behalf of all of the people that are listening. We're going to move on now to the next speaker, which is going to be Chris Smith. So if we could put Chris's video up, please.
Hello, I'm Dr. Chris Smith, and this is an evaluation of the Good Sam Volunteer First Responder app for out-of-hospital cardiac arrest. I'm funded by the NIHR, and this is their disclaimer. and I'm a PhD student currently working at Warwick Clinical Trials Unit. I'm taking data from GoodSam, who are a not-for-profit social enterprise company, and the National Out-of-Hospital Cardiac Arrest Outcomes Database hosted at the University of Warwick. So this chap's had an out-of-hospital cardiac arrest, and we know that CPR and defibrillation will substantially increase his chances of survival. We also know that these are two interventions that can be performed by bystanders before the ambulance arrives, and the trick is trying to get that to happen. A number of countries have volunteer first responder apps, whereby somebody has an app on their phone, and if they are in the vicinity of a cardiac arrest, they receive an alert on the phone, and then they can then choose to go and provide assistance if they're able to. In the UK, the predominant system is GoodSam, and this is integrated with a number of local ambulance services, so that if during an emergency call a cardiac arrest is diagnosed by the call handler, an alert is automatically sent out to the mobile phone of somebody with the GoodSam app if they are in range. They can then decide to accept the alert and provide assistance or not. And if there are public access AEDs in the vicinity, then those will display on the screen as well, giving them the opportunity to retrieve an AED en route. So the aim of this project was to evaluate the impact of GoodSam on survival to hospital discharge in two ambulance services where it's been introduced. So that's the London Ambulance Service and the East Midlands Ambulance Service. I took data on confirmed cardiac arrests where resuscitation was attempted by EMS from the out-of-hospital cardiac arrest outcomes database. And I had data on all GoodSam alerts taken in the same time period. And I matched, using location and time of incident from both data sets, each GoodSam alert to its relevant cardiac arrest. I constructed a logistic regression model into which were factors known to potentially influence the outcome of cardiac arrest. And they're there on the screen for you. At the bottom, GoodSam alert status, we decided to look at differences in outcome where a GoodSam alert was accepted, where one was rejected, and in cases where no alert was sent out. So in London, and this is data over 12 months from April 2016 to March 2017, there were just under 4,200 cardiac arrests, and a GoodSam alert was sent out for 282 of these cardiac arrests, that's 6.7%. At the time, the alerting radius in London was 300 metres, so that means there were 282 cardiac arrests where there was a GoodSam responder within 300 metres of the arrest at the time. The overall acceptance rate was 1.3%. However, when an alert was accepted, the adjusted odds ratio for survival to hospital discharge compared to no alert was 3.15. A wide confidence interval, but meets the threshold for statistical significance. In the East Midlands, in a 6-month period in 2018, there were just over 1,000 cardiac arrests, and a GoodSam alert sent out for 227 of those, as 22%, and the alerting radius at the time in the East Midlands was 800 metres. Overall, an alert was accepted for 5% of cardiac arrests in that time period. With a similar result in that the adjusted odds ratio for survival to hospital discharge when a GoodSam alert was accepted was 3.19. Again, a wide confidence interval, but again meeting the threshold for statistical significance. So what now? So ongoing work that I'm conducting at the moment is to try and validate those results in a contemporary data set from both London and the East Midlands. and doing a little bit more work to determine what happens after a Good Sam alert is accepted, focusing particularly on whether the person who accepts the alert gets to the scene before the ambulance arrives, and exactly what interventions they are providing. And sort of in conjunction with that, some work to optimize the response radius. If your response radius is too small, then you don't activate enough responders, and not enough people can potentially benefit. If the response radius is too wide, then people get there after the ambulance on too many occasions. And we know from other work that we've done but not presented here that this demotivates them from responding in future. So it's just for me to say thank you to the number of people that have helped me. So at the University of Warwick, Professor Gavin Perkins and Professor Ranjit Lal, Dr. Rachel Fothergill at London Ambulance Service, and Mr. Rob Spate at East Midlands Ambulance Service, and from Good Sam, Mark Wilson, Ali Gorbangali and Deepti Bal. The take home from this work is that a Good Sam alert is accepted infrequently. When it is, it's an independent predictor of survival to hospital discharge in 2 different ambulance services. But we need to know a little bit more about what happens then, and what happens when an alert is accepted, to tease out exactly why accepting an alert is providing benefit to patients. And I'm available for questions. Thank you.
Great, thank you very much, Chris, for a nice presentation. So we're going to move to Kate Berg first, who's going to pose a question to you.
Great, thank you. That's a great presentation, and I admit I find this technology very exciting. One thing that struck me in your data is that of the alerts that went out, it was really a relatively low percentage of people who accepted the alert and responded to it. And I wonder if you have any information on whether there was anything that influenced the likelihood that somebody would accept it. You know, was it how far away they were, or what setting the arrest, whether the arrest occurred in a private versus a public location? I don't know if you have that information.
We've done a little bit of work looking at why people did or did not accept. I mean, sometimes it's situations outside of their control. They're with dependents, or they're in a work situation. They feel they can't leave. They've indicated in an interview study that sometimes, yes, if they thought it was too far away, or they thought the ambulance response time was likely for the ambulance to get there before them, then they wouldn't attend. Quite a few of our responders had responded on multiple occasions, and those that had found themselves arriving after the ambulance service in the past, or arriving at non-cardiac arrest, indicated that potentially demotivated them a little bit from responding, because they're giving up their time and not potentially being able to help as much as they would have liked.
And I think there's a couple of questions in the chat too, but sort of related to reasons for responding or not. Is there any data yet on whether there's variability depending on, what country or what setting an app is used in? I think the trials have mostly been done in Europe, and I know people have questioned whether it would translate in the United States, for example, if the responses would be similar.
I've only got Good Sam data from 2 areas in the UK. I mean, I know, for example, there's work being presented this morning on the Heart Runner app in Denmark and Sweden. They seem to get better response rates. Why it's lower in the UK compared to other settings, I'm not entirely sure. I think it's worth saying that this work applied to just after the app had been introduced in both ambulance services. And I talked about the validation work I'm doing on some newer data sets, and our acceptance rates in the latest data are closer to sort of 10 or 15%. So they are creeping up as the technology becomes embedded. I'm sure some of it is just awareness of the app itself. There's probably a massive body of work to be done on why so few people are accepting. Whether it's transferable to different settings, I don't know. I doubt it. I suspect there's great differences between how a population views their responsibility to respond to a cardiac arrest in different parts of the world.
Great. So some lots of questions coming in on the Slido app. So, but Bernd and others have asked a couple of questions in relation to, have you got any data on what the people did when they arrived? And do you know, for example, whether patients were in a better state when EMS arrived, for example? You know, were they more likely to be in VF?
Crude figures, there's very little difference in slightly higher VF rates, but these are sort of crude unadjusted figures. I think it was something like 25% in the accepted Good Sam group versus closer to 20% in the other groups. From this data set, I can't tell you what people did when they accepted. There is more. We have done more recent work, but I'm not in a position to present that at the moment, I'm afraid.
Okay, and two very quick questions in the interest of time. Did time of day make any difference, and what do we know about the demographics or the characteristics of the people that were responding? Were they lay people, healthcare professionals?
Time in this analysis, time of day we didn't account for. In the more recent data sets, time of day didn't make a difference to the likelihood of response, which is perhaps counterintuitive. I can't tell you what the breakdown of lay responders and healthcare responders is. I didn't have that data available at the time.
Great. Okay. Well, thank you very much for responding positively to those questions, Chris. We're going to move now to the next presenter, who's going to be George Smoser. Many thanks.
Good morning, everyone, and thank you to the organization committee for allowing me to present our data today. We have nothing to disclose. Respiratory failure is the most common cause for pediatric cardiac arrest, and therefore ventilation is more important during CPR compared to adults. Children with asphyxial cardiac arrest have a higher 30-day survival and a more favorable neurological outcome with chest compression and rescue breaths combined versus chest compression alone. The current ILCA recommendations are to use a 15:2 chest compression to ventilation ratio during bag and mask ventilation, and once the secure airway has been established, to use continuous chest compression with asynchronized ventilation at a rate of 10 to 20 per minute. However, the optimal compression to ventilation ratio during pediatric CPR remains unknown. Adult animal studies reported that when you use a constant high distending pressure, which is superimposed during chest compression, you could see an improved hemodynamic response, could be systemic as well as pulmonary artery pressure, as well as achieving passive lung ventilation and thereby allowing adequate oxygen delivery. We have studied chest compression with high distending pressure, which is called sustained inflation in the neonatal world over the last 8 years. And our main approach was always to compare that to the 3:1 chest compression to ventilation ratio, which is recommended by the Neonatal Task Force of ILCOR. Our animal studies showed a reduced time to ROSC by 75%, a 50% improvement in survival, as well as significantly improved systemic and regional hemodynamics, minute ventilation, and oxygen delivery. We also were able to show and demonstrate that CCSI can achieve passive ventilation of the lung. A parallel delivery room study comparing CCSI versus 3:1 in our center also showed a significant reduction in time to ROSC. We currently are running a large randomized controlled trial, the SURVIVE trial, comparing CCSI with 3:1 in the delivery room. While CCSI has been examined in the neonatal world, evidence in pediatric and adult population is lacking. Therefore, our aim was to compare CCSI with CCAV during CPR in asphyxiated pediatric piglets. Our PICO question was that in pediatric piglets, CCSI compared to CCAV will reduce the time to ROSC during CPR. Our sample size calculation was based on the premise that the CPR time to ROSC will be reduced using CCSI. Our previous data showed that with CCAV, our chest compression time was a mean of 70 seconds. If we were able to reduce this time by 20%, which we regarded clinically important, we would require 12 piglets per group. As this was a randomized control animal study, we randomized piglets at a two-step process to control or intervention initially, and at the commencement of chest compression, we commenced them either to CCSI or CCAV. Our randomization allocation was block randomized with variable block sizes using a computer-generated randomization program with a two-step randomization process. At any time when we opened envelopes, these were sequential numbered sealed brown envelopes. This is our flow diagram, and we used our well-established animal model where after animal preparation, the animals are allowed to stabilize for 60 minutes. At that time, we do the first randomization, either to control or intervention. Control animals then go on to be monitored for 4 hours and then euthanized. Intervention animals, they experience asphyxia by clamping the endotracheal tube. When our cardiac arrest was defined, we ventilated for 30 seconds with positive pressure ventilation and then randomized to one of the two interventions before CPR was started. After ROSC was achieved, the animals were allowed to recover for 4 hours. Here are the baseline characters at the end of stabilization, which were similar between sham, CCSI, as well as CCAV. At the time of commencement of CPR, there was also no differences between the hemodynamics as well, the blood gas values between CCSI and CCAV. Our primary outcome was time to ROSC, which was significantly decreased in the CCSI group with 248 seconds compared to 720 seconds in the CCAV group. We also observed a 100% higher rate of ROSC in the CCSI group compared to the CCAV group, 10 versus 5. Overall, 7 of the 10 piglets in the CCSI group survived to 4 hours, and 4 of 5 piglets in the CCAV group. Because the piglets in the CCSI group had a faster time to ROSC, the number of intravenous epinephrine boluses were lower compared to CCAV. I previously mentioned that CCSI allows for passive lung ventilation, and here you can see 2 respiratory graph figures. The top figure is CCAV, where you can see PPV, and then chest compression starts, and you can see that there is some small movements of flow. Every time you squeeze the chest, some gas comes out, and when you release the chest, some air comes in, but the total volume delivery is rather minimal, and it's around 3 to 5 milliliter total. Any of these peaks are somewhere around 6 to 10 kilos. So if you have a 3 to 5 milliliter total volume delivery, this is rather small. On the bottom, you see CCSI, and you can see again, during chest compression, gas comes out of the lung, and during the release phase, gas goes into the lung. The total volume is somewhere around 20 mils per chest compression, and this is, in our opinion, a good total volume when you do a chest compression rate of 100 to 120 per minute. In addition, not only that you get passive lung inflation, you also get some lung recruitment. With CCAV, we found that per CCAV cycle, with 6 to 7 chest compressions between each ventilation, you lose roughly 6 milliliter per this cycle of air out of the lung, so you get a continuous de-recruitment. In the same time, over this time frame, you get a volume gain of 1 milliliter with using CCSI. There was no difference in any hemodynamics throughout the observation period. And in conclusion, CCSI reduced the time to ROSC and improved survival compared to using CCAV. CCSI allowed passive ventilation of the lung while providing chest compressions, and this technique warrants further studies to examine the potential to improve outcomes in pediatric patients with cardiac arrest. I would like to thank everyone at CSER, and I'm happy to answer any questions. Thank you.
Great, thank you very much. We can now open this for questions, and I think Marcus is going to go first.
Okay, thank you, Professor Schmaltz. A very nice presentation. So this technique, is it, I'm an adult intensivist, I only treat adults. So would this be similar to doing CPR with PEEP? You would apply a PEEP valve on an intubation tube and then do chest compressions?
Yes, it's quite similar. So, but you need a high PEEP. So it's not just a PEEP of 5 or 10. In our newborn model, we use at least a PEEP of 30 or 25 centimeters water. So and you would do the same in the pediatric or adult model. You would use a high PEEP around 30 centimeters of waters to get the gas moving in and out.
Yeah, and then the other question. So you present much higher ROSC rates, but not much difference in the physiology that you present, you know, the heart rate and cerebral saturation and those sort of things. So why did the piglets get more ROSC?
It's an excellent question.
If you improve, you know, the lung, the way the ventilation is occurring. So I mean, the only thing that you could think of is improved oxygenation. You know, much higher oxygen, and that would help the heart start or something like that.
Yeah.
But do you have a hypothesis?
Yeah. So I mean, we in our initial study several years ago, we had like pulmonary artery blood flow, pulmonary artery pressure. So in those initial studies in newborns, pulmonary artery blood flow, pulmonary artery pressure, carotid blood flow were all higher. We didn't see the carotid blood flow higher in this study. But you can see that when you do chest compression with this high airway pressure, that you can see a better blood flow on the blood flow. Like if you monitor carotid blood flow, and every time you stop your high airway pressure, because every 20 to 30 seconds you release that high airway pressure to get the gas out, so that you don't have an increase in CO2. You can see that your carotid blood flow decreases, and then once you restart the sustained inflation or that high PEEP, your carotid blood flow goes up again. So I think the flow is improved, and you also get better oxygenation. So I think this is a combination of better oxygenation, maybe a little bit improved blood flow, which doesn't reach significance in a small number of pigs we use for any of these studies.
Okay, so but the near infrared spectroscopy wasn't different. But have you looked at, you know, for example, invasive oxygen in the brain? Is that improved with this technique?
We haven't looked at invasive oxygen. I mean, the problem with our NIRS device we use is that once the NIRS is displays 15, that's the lowest number it does. So I don't know if there is below that value there's any difference. So we've never done invasive oxygen measurements because we don't have that technology in our lab. We've seen in some of our newborn studies that the oxygen injuries are less. So there's lower injury from oxygen related in the brains of our newborn piglets. We haven't analyzed the brains of the pediatric yet.
Okay,
Gavin. Yeah,
if it's okay, we've got a few questions coming in, so I'm going to go to Rocky first, and then Kate Berg, who's picked up on a couple of questions that Bernd and others have asked. So Andy.
Sure, thank you. Just a quick question. First of all, thank you for a very fantastic presentation. Just for clarity, you've concluded about the benefits of the experimental group as opposed to the control group, and yet when you look at the data for the survival to 4 hours, it's 70% in the experimental group, but 80% in the control group. So how does that fit with your conclusion that the experimental intervention is better?
Well, I mean, our primary outcome was time to ROSC, so certainly the experimental group is better in that approach. It is, I mean, it was for us quite surprising that the experimental group had a higher death rate, but because if you look at our newborn data, it was always the opposite, that the CCSI group, even for 4-hour period, had a significant higher survival rate. So I really can't explain it why in that study it was the opposite, but we also don't really do anything to help those pigs.
I'm going to move you very quickly to a final question from Kate, if that's okay.
Oh, thank you. So I think, and this relates to Bernd Boder's question also, What do you think the mechanism is for the change in blood flow during CPR? Because I would have thought that with the higher intrathoracic pressure, you might actually get worse, blood return and therefore worse circulation, but you're finding the opposite.
Yeah, so certainly, if you do a high airway pressure, you get a higher intrathoracic pressure. Chest compression is thought also to increase intrathoracic pressure. So we think it is some increase in intrathoracic pressure, but our CVP is not really increasing. It's not significantly higher to any other of the resuscitation techniques. So there's not impaired blood flow if you look at CVP, for example. So I think it's, as you mentioned, that increase in intrathoracic pressure, which gets the blood flowing. But given our limitations so far in what we can do from instrumenting those picklets, we couldn't really narrow down yet the exact way of why it works or why it doesn't work.
Okay, terrific. Well, thank you again for an excellent presentation. In the interest of time, we're going to move on to the next presenter, Karina de Graaf. If we could play the video first, please. Thank you.
My name is Karina de Graaf, and I'm a PhD candidate from the Amsterdam Resuscitation Studies, also known as ARREST. Today I would like to tell you about our research on a new AED algorithm called CPR Insight, which can analyze the heart rhythm during chest compressions and the comparison with a conventional AED. This is my conflict of interest. And before I'm going to show you our results, I will first explain some things about AED rhythm analysis and the differences between a conventional AED algorithm and CPR Insight. As you all may know, the standard settings of AEDs prompt the user to stop chest compressions every 2 minutes. This means every 2 minutes chest compressions are being interrupted, as you can also see in the figure, and although necessary, every interruption in chest compressions influences the outcome of the patient. With that in mind, a new AED algorithm was developed called CPR Insight. CPR Insight can analyze the heart rhythm during chest compressions, which means chest compressions are not interrupted for rhythm analysis, and the user only has to stop for shock delivery. In AEDs with the CPR Insight algorithm, the first analysis is a conventional analysis, which immediately starts after the electrodes are connected. This is due to the fact that CPR Insight needs approximately 30 seconds for rhythm analysis during chest compressions, and you don't want to delay the time to first defibrillation. After analysis 1, every subsequent analysis will use the CPR Insight algorithm. CPR Insight can classify the rhythm as shockable, non-shockable, or pause needed in case of CPR Insight cannot make a shock or no shock decision. In case of the pause needed scenario, a conventional analysis will follow. To explain this a little bit more in detail, at the top we can see a standard AED with a conventional AED algorithm. In AEDs with the CPR Insight algorithm, as I just explained, the first analysis is exactly the same as a standard AED and uses a conventional AED algorithm. After analysis 1, CPR Insight is activated and will start at 1:30 with rhythm analysis during chest compressions. At 2 minutes, there's a shock decision and only a small pause for shock delivery in case of a CPR Insight shock decision. In case of a CPR Insight no shock decision, again at 1:30 CPR Insight will start with the rhythm analysis during chest compressions. At 2 minutes there's a no shock decision and no pause is prompted, the user just continues with chest compressions. In case CPR Insight cannot make a shock or no shock decision, it will prompt for a pause at 2 minutes, after which a conventional analysis will follow with exactly the same length as a standard AED. With this in mind, you can imagine when an AED with CPR Insight is used in an out-of-hospital cardiac arrest cases, there are two things that will happen. The amount of chest compressions being given in the same amount of time will be higher, so this will lead to a higher chest compression fraction. And in case of a shockable rhythm, the pause before shock delivery will be shorter, in theory. Well, to test this theory, we used data from Amsterdam Fire and Amsterdam Police, which used in 2016 and 2017 conventional AEDs, namely LifePack 1000 defibrillators. This will be our control cardiac arrest cases. In 2018, they replaced all their AEDs with a CPR Insight algorithm, namely LifePack CR2s. We will use the years 2018 and 2019 for intervention cardiac arrest cases for this comparison. We compared the chest compression fraction and pre-shock pause for all 2-minute cycles and shocks, excluding analysis 1 due to the fact that in both devices this analysis is exactly the same, and accounting for multiple observations per patient. The chest compression fraction was defined as the proportion of chest compressions between the start of CPR after an analysis until the start of CPR after the next analysis. Pre-shock pause was defined as the time between the stop of CPR until the delivery of the shock. On to the results. In total, there were 465 out-of-hospital cardiac arrest cases in the control periods and 425 out-of-hospital cardiac arrest cases in the intervention periods, excluding all the cases with only one analysis, leaving us with 418 cases in the control period and 365 cases in the intervention period. Taking all analysis into account, that left us with 852 analyses in the control period and 726 in the intervention period. Of all these analyses, the chest compression fraction was calculated, leading to the fact that intervention cases had a significantly higher median chest compression fraction, namely 86% compared to 80% in the control cases. For calculation of the pre-shock pause, we could only use cases with a shockable rhythm, leaving us with 158 control analyses and 118 intervention analyses. Of these, we calculated the average pre-shock pause, and we found that the median pre-shock pause was significantly shorter in intervention cases, namely 8 seconds, compared to 22 seconds in the control cases. In conclusion, compared to conventional AEDs, the use of CPR Insight leads to a significant increase in chest compression fraction and significantly shorter pre-shock pauses. These are promising results, but we're not there yet. Future research is necessary for the comparison of outcome variables, such as return of spontaneous circulation and, in the end, of course, survival. Thank you for your attention, and I'm happy to answer any questions.
Thank you for that very nice presentation. We're going to open the questions with Kate Berg, please.
Great, thank you for that great presentation, very interesting data. I had one question about the algorithm with the newer AED, and then what I know you said that sometimes it does require a pause for a conventional rhythm analysis, and I just wondered if you have a rough idea of how often that happens.
In 30%, so in 70% of cases, the algorithm can make a decision during chest compressions, and in 30%, it cannot make a decision and a conventional analysis will follow. And looking even into more detail, we see that it is most often that is during asystole. So during asystole, the algorithm most often cannot make a decision.
Okay, interesting. And then my other question was were there any difficulties in getting the EMS agencies using the new algorithm to kind of accept and trust it?
Well, of course, it were police and fire, so they are separate from the EMS agencies. And when we came into contact and discussing this, they said, well, it's just a next AED. So, well, they were, of course, in front, get to notice the device a little, but for them, it's just the next AED.
Right.
So we encountered not that many problems introducing this new device.
Great, thank you. And I see there are a couple other questions, Gavin, if you want to go to those.
Sorry, questions from our audience. So from our Director of Science of the ERC, Bernd Bottiger, do you have any outcome data and why are you not doing a randomized controlled trial?
Well, the first part of the question, I don't have any outcome data yet because we have not that amount of numbers to really calculate the outcome data, because then you have to adjust for the whole chain of survival. So this is of course only a small part, only new technology in an AED, but you also have to adjust for things like the ALS treatment, response times, patient characteristics, and there you need more numbers to adjust for. So I don't have any outcome data yet. And why it wasn't a randomized controlled trial, because all the AED devices of the police and fire were replaced with a new one. And this was due to the fact that they wanted to replace all their old devices with new ones. So we kind of jumped into that and said, okay, well, you get this new device and we will use the data to compare it with the period before. So that's why it wasn't possible for us at the time to make it a randomized controlled trial.
Okay. Another question is there a machine learning algorithm which predicts when an AED shock is going to be successful?
Well, at the moment, not with this technology, no.
And are you aware if there were any inappropriate shocks or shockable rhythms that were missed by the algorithm?
Yeah, we did compare also the sensitivity and specificity of both devices, and they were both according to the guidelines. So the and there were not significantly different. So I don't have the specifics for you at the moment, but they were both performing according to the guidelines and they're not significantly different. So there were not both 100%, but that every device has a small proportion of false negatives or false positives, but they were both performing according to the guidelines and well above the lower threshold.
Okay, terrific. Well, great. Thank you very much for your presentation and for responding to those questions. Much appreciated. We're going to move now to our final presentation that's going to be delivered by Bernhard Kalowski.
Welcome, ladies and gentlemen. Greetings from Austria. My name is Bernhard Kowalski. I'm a paramedic and just became a medical doctor. The name of this study is Non-Technical Skills in ERC CPR Competition Teams, an observational study. If you take a look to the picture on the right side, this is a sneak peek of what the study is going to be about. Let's start with a definition. Non-technical skills are interpersonal and cognitive skills that are responsible for effective teamwork. I like this definition a lot, and I want to highlight the term skills because skills are trainable, and something that you can train, you also can improve on. An estimated 70% of medical errors happen due to the breakdown of NTS. This is quite a high number, and it also means that there is huge growth potential in this field. The purpose of the study was to explore the impact of NTS use on the performance of medical emergency teams. We were looking at the ERC CPR competition 2018, which was held in Italy and, to be more precise, in Bologna. We compared the finalist teams with the non-finalist teams, and the null hypothesis was that the finalist teams did not use more NTS than the non-finalist teams. Let's see if this is true. Material and methods. Step 1 was the selection and clustering of 27 NTS tools. This was done by literature research and best practice according to our local protocol. After that, we clustered the tools using the crew resource management molecule. Step 2 was the acquisition of the video material. As already mentioned, we decided to use the ERC CPR competition 2018. The video and audio material both were excellent, and we had 12 international teams participating in a standardized adult CPR scenario assessed by professional judges. Most importantly, the NTS use was no criterion to enter the finals. Step 3 was the video assessment done by one reviewer, which was me, and I spent many hours scoring the use of each predefined NTS tool in Final Cut Pro. The last step was the statistical analysis, where we compared the finalist group consisting of 3 teams with the non-finalist group consisting of 9 teams. So let's jump to the results. I was pretty astonished when I saw the results because the finalist group scored higher in every analyzed NTS tool than the non-finalist group. On this graph, you can see how much higher the finalist group scored for each specific NTS tool. If we look into the results with a little bit more detail and look at the scorings that were at least 70% higher from the finalist group than the non-finalist group, we made the following observations. Looking at the finalist teams, they used the start-stop system more frequently than the non-finalist teams. Looking at the finalist team leaders, they verbalized more H's and T's, they gave more and more clear instructions, and that's one of my favorite points, they asked their team more questions. Let's look at the finalist team members. This was no huge surprise to me. They used more closed loop communication with repeat back method. For clarification, repeat back method means that you fully repeat the instruction you just received. They cited more names, and another of my favorites, they gave more suggestions to their team leader. So dear team leader, ask your team more questions. And dear team member, give more suggestions to your team leader. Limitations, the sample size. We analyzed 1 competition. The review team consisted of 1 reviewer, which was part of a team, which was me. The group size was uneven. The finalist group consisted of 3 teams and the non-finalist group consisted of 9 teams. And there were camera and scenario restrictions. Let's end this presentation with the conclusion. So for this study, the finalist group scored higher in every analyzed NTS tool than the non-finalist group, although this was no criterion to enter the finals. We came to the conclusion that NTS seemed to play an important role for improved team performance of medical emergency teams. For future studies, we are going to analyze more consecutive CPR competitions, and we are going to use multiple reviewers. And a very interesting point, we are going to try to establish a standardized scoring tool to quantify the use of NTS in medical emergency teams. Ladies and gentlemen, thank you for your attention. Greetings from Austria. Have a nice day. Bye-bye.
Thank you again for a very nice presentation. I'm going to open the questions up by handing over to Andy Lockie.
Thank you very much, Gavin, and thank you very much, Bernard, for a very, very good, clear presentation there. I think probably the concern that's actually coming through on some of the questions at the moment is for your sanity after being the one reviewer to sit through all of those videos. Were you concerned, was there no stage where you wanted to get another reviewer to just reduce bias?
That's an excellent point, actually. It was a pilot study and, as you mentioned, quite a lot of work. And for future studies, there definitely will be more reviewers. That's yeah, an obvious point.
Just out of interest, who were the finalist teams that year?
In 2018,
yeah.
It was it was Austria. It was.
I thought it was. And of course, being Austrian as well, was there any bias there at all?
Definitely, that's also something that I mentioned in the presentation. There was that bias, although the study was done 1 year after the actual competition. So at the point of the competition, I didn't know that this is going to happen.
Okay, and I guess my final question is and you briefly mentioned this in the conclusion, but what is, you've done an analysis of a competition in a conference. Where will this take us next?
So personally, I have a very clear vision. I think non-technical skills need to be precisely defined, so you can train them and you can assess them. And in my opinion, they should be used in a certain context. So I call those NTS or resuscitation non-technical skills. And ideally, in my perfect world, they will be taught. So we have a lot of upcoming generations. For them, it should be normal to do this kind of things. And therefore, we need more robust data. And that's what it's going to be about. More competitions, more reviewers, more robust data.
Thank you very much. No further questions, Gavin.
So thank you. I think Marcus has a question.
Yeah, a little bit related to the previous ones. So were all the teams only speaking English? Or how were you able to score their
yes, the
communication?
So it was an international competition, so you had teams from all over the world, but the used language was English.
I guess the other question is, I mean, of course, this is a team, where you practice to take part in this competition. So if you would do this, with regular doctors who working in ICUs, who don't train, who perhaps not that interested in CPR, what would you think that would be the difference in results?
So I think even this competition shows the results, because I'm pretty sure by analyzing all those videos that not all teams have trained together. And I'm also very sure that probably just some hospital teams said, okay, we are going to take part. Personally, I think the correct use of non-technical skills is absolutely essential. And if you do not train them, you are a team of experts that has no... it's way harder for them to perform at their peak level. That's what I think. So
one final question. So a number of people in the chat have been, raising concerns about the potential risk of bias, both from having a single observer, but also I guess the language and the ability that non-technical skills may be easier in your native language. If you were going to do this study again, or I guess the next version of this study, what steps could you take to reduce these biases?
As I already said, so we need multiple competitions, we need multiple reviewers, and probably also look at some different competitions as well. I mean, this obviously is the Premier League, but there are different competitions as well. And in those competitions, it's also possible to talk in your own language. So those would be the main steps that I suggest.
Okay, terrific. Well, I'd like to congratulate you, and indeed congratulate all of the speakers in this session. You've done an outstanding job. You've been selected as the European Resuscitation Council Best of the Best abstract. So cordial congratulations to you all, and do tune in for the closing ceremony where the results of this competition will be announced. Thanks very much to the audience for your time and attention, and thanks everyone else for your participation. Thank you.